everyone, welcome to USDTL's ToxTime, testing for SSRIs in umbilical cord tissue, improving outcomes for newborns. We are so excited to have Amy Racines as our presenter today. Amy Racines is the Research and Development Projects Coordinator at USDTL, where she develops and validates new extraction, immunoassay, LDTD, MS, GCMS, and LCMS methods. She holds a master's degree in forensic science from the University of Florida and has been with USDTL for over a decade. Amy has papers published in scientific journals related to umbilical cord research and mass spectrometry, and is a member of many forensic and science related organizations, including the position of previous president of the Midwest Association of Toxicology and the Therapeutic Drug Monitoring, and Chicago Chromatography Discussion Group. Please note that the opinions shared during this session are those of the presenter and do not necessarily reflect the official policies or positions of USDTL. With that, we're so excited to get started, and I'm pleased to introduce Amy Racines.
Thank you so much for that introduction. Today we will be talking about SSRI exposure during pregnancy, the risk to newborns. I do have a quick disclaimer. I am an employee of the United States Drug Testing Laboratory, or USDTL, and USDTL is a commercial provider of forensic toxicology testing services. Any opinions expressed in this presentation are that of my own and do not represent USDTL. So here is an outline so everyone knows what to expect from this presentation. So we will start with a brief history of antidepressants and their categories, and we will talk about which ones are no longer used and which categories are currently being prescribed today. We will then briefly talk about the chemistry behind SSRIs and how they work in your brain to fight both depression and anxiety. We will then move on to talk about SSRI use during pregnancy and the potential effects SSRI use during pregnancy can have on the baby. Similarly, we will also discuss the potential effects that depression during pregnancy can have either on the baby or the pregnant individual. And lastly, we will cover the importance of testing for this specific category of medications. So before we talk about the history of antidepressants, I do want to get started with this poll question. So it's kind of a pop quiz to test your knowledge. So the question is, which of the following is not a classification of antidepressants? SSRIs, TCAs, ACE inhibitors, or SNRIs? So I will give everyone a minute to answer. Okay, so the correct answer is ACE inhibitors. That is actually a medication for blood pressure. The rest of these are classified as antidepressants. So let's talk about them. The first generation of antidepressants consisted of tricyclic antidepressants, or TCAs, and monoamine oxidase inhibitors, or MAOIs, which were first released into the market in the 1950s. Prior to this time, there was no medication for people suffering from depression or anxiety. So the development of these medications was hugely beneficial and a great improvement to treatment. Unfortunately, however, they quickly discovered that there were several problems with these medications. These drugs, more specifically the TCAs, were easy to overdose on, and the overdose could result in death. As you can imagine, it is less than ideal to prescribe a medication that is easy to overdose on to someone suffering from depression, whether that overdose is intentional or not. But even if the medication was taken as prescribed, there were still many disruptive side effects, like dry eyes and mouth, constipation, and urinary retention, all of which are very uncomfortable. So what was happening was that people would stop taking the medication to avoid the side effects because they believed that the side effects were not worth the benefit to their mental health. So as you can imagine, all of this was very problematic with these first-generation antidepressants. So this is a study that highlights the non-compliance of the first-generation antidepressants. In 2001, they studied 88 individuals who were prescribed a tricyclic antidepressant, and they determined their compliance to the medication at various intervals throughout the study. After 6 weeks of taking the medication, 72% of the individuals were compliant, but after 12 weeks, only 57% was still compliant with their medication. This is especially concerning because the medication typically has to be in the system for 3 months before it is effective. So the individuals stopping prior to this time received no benefit from taking the medication. It is also possible that this delayed effect of the medication could contribute to the noncompliance observed with TCAs. If individuals taking this medication don't feel relief from taking the medication after multiple weeks of negative side effects, they may not be motivated to continue taking the medicine for the duration needed to experience the desired effect. So as a response to those problems of the first generation antidepressants, in comes the second generation of antidepressants. SSRIs were first released in the 1980s, and the first SSRI released to the market was Prozac. These drugs were much safer and had significantly less side effects. Prozac, as a matter of fact, received the nickname of the wonder drug since it was effective in many patients, and it marked the beginning of a new era of safe and effective treatment for patients with depression. Today, Prozac is still one of the most widely prescribed antidepressant drugs in the world. The only problem with SSRIs as a class was that they were not as effective as the first generation antidepressants at treating more severe cases of depression or anxiety. So, as a result, SNRIs were developed, which are safe, just like SSRIs, but they are more effective at treating these severe cases of depression than SSRIs. And this is where we stand today with antidepressant medications. So what are the symptoms of depression? As I'm sure everyone is aware, depression is associated with feelings of sadness and hopelessness, and individuals can experience angry outbursts and irritability or frustration over matters that may seem small. Individuals can experience a loss of interest in things they used to be interested in, and they can experience sleep disturbances, either too much or too little sleep. They can also experience changes to their appetite, either an increased or decreased appetite, which can cause weight gain or weight loss. Individuals can feel worthless or have trouble concentrating, making decisions, or remembering things. In more severe cases of depression, individuals can have thoughts of death or suicide. And lastly, depression can manifest as unexplained physical problems, such as back pain or headaches. So overall, depression can look very different in different individuals. The next natural question is, what causes depression? So this is a very loaded question, which we don't necessarily have the answers to. But what we do know is that it tends to run in families, so there may be a genetic aspect to it. It can be triggered by a life event, but this is not always the case. And lastly, what we will focus on for part of this presentation is that it may be caused by chemical changes in the brain. It has been found that people suffering from depression have increased levels of monoamine oxidase A, and that is an enzyme that breaks down neurotransmitters. Two of those neurotransmitters are serotonin and norepinephrine. So if there is an increased amount of enzyme that breaks down neurotransmitters, the end result is a low level of neurotransmitters. So this is actually the key takeaway from this slide, is that depression is linked with low levels of serotonin and norepinephrine. So what is serotonin? So serotonin is a neurotransmitter, which is essentially a messenger for your brain. Your body has various neurotransmitters, each of which have different and very specific functions in the body to help regulate moods, body processes, and reactions. Serotonin is responsible for regulating mood, sleep, bone health, wound healing, sexual drive, and many, many more activities not listed here. Serotonin is actually one of the main neurotransmitters in the body. So norepinephrine is another major neurotransmitter, which is responsible for maintaining blood pressure, increasing your attention, regulating the sleep-wake cycle, regulating mood, and regulating the memory. So let's move on to SSRIs. SSRI stands for Selective Serotonin Reuptake Inhibitor. So this is a class of drugs that can be used to treat depression, anxiety, or other psychological disorders, and they currently account for about 70% of antidepressants prescribed. SSRIs function by blocking the reabsorption of serotonin into neurons, which causes an artificially high level of serotonin in the brain. Okay, so that's a lot of words, but what exactly does that mean? So I have this picture to help explain how SSRIs work in the brain to treat depression or anxiety. Pictured here are two neurons which are located in your brain. These green squares represent serotonin. The space between the neurons is called the synaptic cleft. This top neuron is the presynaptic nerve terminal, and the bottom one is considered postsynaptic. In a normally functioning brain, serotonin is stored in the presynaptic neuron in these membrane-enclosed vesicles. When the neuron receives a signal, this vesicle moves to the edge of the nerve terminal and releases serotonin into the synaptic cleft. In the cleft, serotonin binds to the receptors in the postsynaptic neuron, which is what causes the signal. When they are done binding, the serotonin leaves the receptor and travels through a transporter back into the presynaptic neuron so it can once again be stored in a vesicle and wait for the next signal. So this is how serotonin normally functions in the brain. SSRIs work by binding to the transporter protein. So this blue rectangle represents SSRIs. This binding prevents the serotonin from traveling back into the presynaptic neuron. So it essentially traps the serotonin in the synaptic cleft. When the serotonin is trapped in the synaptic cleft, it will continue to bind to the receptors and create more and more signal. So this is beneficial to individuals suffering from depression because depression is associated with low levels of serotonin. So if serotonin is trapped in the synaptic cleft and not able to be recycled back into the presynaptic neuron, it essentially tricks the brain into thinking that there is more serotonin, which compensates for the low serotonin associated with depression. So this is how SSRIs work. So let's move on to SNRIs, which hopefully you remember are also a part of the second generation antidepressants. They were developed because SSRIs were less effective at treating severe cases of depression or anxiety. SNRI stands for Selective Serotonin and Norepinephrine Reuptake Inhibitors. It is very similar to SSRIs in the fact that they work almost the same way in the brain. So the previous slide that we just covered also applies to SNRIs. The only difference is that SNRIs also prevent the reuptake of norepinephrine in addition to serotonin. So that is why this medication is more successful at treating more severe cases of depression and anxiety. So the rest of this presentation will focus mainly on SSRIs, only because SSRIs are more readily prescribed than SNRIs. But because these two classifications are so similar, the majority of this information applies to both classes of antidepressants. And I actually will specify if there are differences in the medications on the topic that I'm talking about. So fortunately, when it comes to SSRI use, the majority of individuals do not misuse the medication. However, there is still a potential to misuse this medication. Individuals can become dependent on the medication and can experience withdrawal symptoms upon termination of the medication. The exact statistics of how many individuals misuse antidepressants is thought to be low, but ultimately it is unknown. So here are a few statistics on the population that we want to discuss today. According to the National Health and Nutrition Examination Surveys, 1 in 20 non-pregnant individuals of childbearing age experience major depression. Women are more likely than men to experience depression. About 10% of women experience depression, and about 6% of men experience depression. Antidepressants are used by 1/3 of those with major depression and 1/5 of those with minor depression. And as we discussed previously, about 80% of antidepressants prescribed today do fall into the SSRI category. And lastly, about 5.5% of pregnant individuals used SSRIs during pregnancy. So what exactly does that mean for the baby? So some babies exposed to SSRIs during pregnancy do experience neonatal abstinence syndrome, but that's only about 30%. So this is not a good indicator of exposure. Some other reported symptoms are tremors, increased muscle tone, sleep disruption, gastrointestinal disturbances, and high-pitched crying. Fortunately, none of this seems severe, and all symptoms usually disappear within 48 hours and did not require medical intervention. So this normally would be a really great thing, having very mild symptoms at birth, and 48 hours later, the baby is fine. Except that the long-term consequences of SSRI exposure in utero can be very severe and can heavily impact that baby's life. To explain these long-term consequences, let's talk about what happens to a fetus's brain in utero if SSRIs are used during pregnancy. So SSRIs do readily cross the placenta, so their brain behaves the same way, entrapping the serotonin in the synaptic cleft. So what does this mean for the baby? So this is a quote from the research article. Although SSRI exposure during development leads to acute increases in serotonergic tone, it inhibits the development of the serotonin system and leads to reduced serotonin later in life. So what this means is that the fetus's brain during development is overwhelmed with serotonin. What happens is that the fetus's brain will regulate itself and intentionally produce less serotonin to compensate for what the SSRI is doing. Unfortunately, since this happens in utero, this is essentially irreversible, and so we see low levels of serotonin later in that baby's life. Other drugs that also alter the serotonin system is alcohol and cocaine use during pregnancy. Now we sort of understand the chemistry of the baby's brain, so how does that relate to the baby's behavior? The first indication that the baby is affected by SSRI use in utero can actually be seen during the pregnancy. In the 3rd trimester, SSRI-exposed babies have blunted fetal movement and lower reactivity to vibroacoustic stimuli. So they are less active and they are less reactive to their surroundings. Additionally, there is reduced fetal heart rate variability and middle cerebral artery flow resistance at 36 weeks gestation. So this actually has the potential to manifest in motor deficits as well as sensory deficits later in that baby's life. So what happens once the baby is born? Unfortunately, there are limited studies on these long-term effects. Studies have focused largely on neonatal outcomes, so there are very limited studies on cognitive behavior beyond 4 years of age. There was a study conducted in 2014 which attempted to look more into these consequences of babies exposed to SSRIs in utero. And this quote describes what behavioral effects can be experienced in these babies at birth. A wide spectrum of neonatal neurobehavioral disturbances have been reported following gestational SSRI exposure, including tachypnea, temperature instability, poor feeding, irritability, weak or absent cry, increased motor activity, reduced heart rate variability, and altered behavioral state regulation. In response to an acute painful event, the duration of facial reaction and cardiac responses, particularly the parasympathetic cardiac activity, is shorter and less intense in SSRI-exposed neonates. Altered response to pain persists at 2 months of age, even after controlling for drug levels and postnatal maternal mood. So essentially, just like what was experienced in utero, these babies seem less active, like eating less, crying less, and less able to regulate their temperature and behavior. Also, just like what was experienced in utero, they are less reactive to their surroundings. This is even the case when the baby is exposed to pain. They are less reactive to it, though it is not clear if this is because they experience less pain or if there is something else going on related to how the signals are happening in the baby's brain. Regardless, it does appear that there is something abnormal happening in the baby's brain. So this study attempted to figure out what that was. This study found that babies exposed to SSRIs in utero have lower levels of calcium binding protein S100B. This protein is a biomarker of early brain maturation and central serotonergic function. So, potentially, these babies' brains are not at the appropriate maturity level for their age. They also have found increased norepinephrine metabolite and thytropin levels, but reduced cord blood levels of insulin-like growth factor 1. This combination could be related to impaired intrauterine growth, which is seen in babies exposed to SSRIs in utero. And lastly, they discovered reduced cortisol levels in blood. This same study did look into development past the newborn phase through early toddlerhood, and they found that infants and toddlers who had been exposed to SSRIs in utero exhibited a poorer psychomotor development index between the ages of 6 and 40 months. More specifically, they determined 3-year-olds exposed to SSRIs in utero were more likely to internalize behaviors, and 4-year-olds exposed to SSRI in utero were more likely to externalize behaviors. And they also had reduced persistence in certain tasks. This study did not define what they meant by internalizing or externalizing behaviors, but they did state that there was a difference in behaviors observed between SSRI-exposed toddlers and non-SSRI-exposed toddlers. In summary, these findings suggest that early neurobehavioral disturbances and pharmacological factors may predict an increased vulnerability to behavioral abnormalities in early childhood. So unfortunately, it does appear that these babies will have issues at least into childhood. As these children age, unfortunately, there is less reliable data. In 2022, a meta-analysis was attempted on the effects of in utero SSRI exposure into adulthood. But ultimately, this was not successful due to inconsistent outcomes that were studied and due to the bias of many of these studies in the literature. They did determine that there was a statistically significant association between in utero exposure to antidepressants and a wide range of physical, neurodevelopmental, and psychiatric outcomes. But that was unclear if it was driven by the underlying maternal disorder. So ultimately, there is a limited number of studies that are looking into these long-term outcomes, which really is a gap in the literature, which hopefully will be studied soon. In addition to the behavioral issues experienced by these babies, there have also been multiple reports of birth defects associated with SSRI use during pregnancy. These birth defects included lung, cardiac, abdominal, and brain birth defects, so these are not insignificant issues. However, follow-up studies were also performed, which would disprove the association of SSRI use in utero being a risk factor for birth defects. So, while there is a lot in the literature, the data has been very conflicting for this specific risk factor. Because of this, a meta-analysis was performed in 2023, and this was a successfully performed meta-analysis. So essentially, all the studies which evaluated the correlation between birth defects and SSRI and SNRI exposure during pregnancy were compiled and looked at as a whole. They then broke down the studies into categories based on the type of birth defect, and they performed statistical calculations to determine which, if any, defects could be correlated with SSRI or SNRI use during pregnancy. So first, they covered the risk of congenital cardiovascular abnormalities. So there were a total of 20 studies which assessed the exposure to SSRI in utero, and 9 studies which assessed the exposure of SNRIs in utero. Common abnormalities among these studies consisted of teratology of Fallot, transposition of the great arteries, ventricular or atrial septal defects, left or right ventricular outflow tract obstruction. The conclusion that was drawn was based on an odds ratio. An odds ratio above 1 indicates a positive correlation between the two factors, and the larger the number, the greater the correlation. For congenital cardiovascular abnormalities, they determined the offspring of women exposed to SSRIs or SNRIs were at a higher risk of congenital cardiovascular abnormalities. The odds ratio associated with SSRI was 1.25, and the odds ratio for SNRI was 1.72. The next category is risk of congenital abnormalities of the kidney and urinary tract. Common abnormalities include hypospadias, renal agenesis or dysplasia, and renal collecting system defects. The offspring of women exposed to SSRIs or SNRIs were at a higher risk of kidney and urinary tract abnormalities. The odds ratio that helped draw this conclusion are listed. The next category that they studied was the risk of congenital malformations of the nervous system. Common malformations include neural tube defects, spina bifida, anencephaly, hydrocephalus, Dandy-Walker malformation, cerebellar hypoplasia, and hollow presencephaly. The offspring of women exposed to SNRIs were at a higher risk of nervous system malformations. However, there was no association observed in the SSRI group. The next category was the risk of congenital abnormalities of the digestive system. Common malformations include esophageal atresia, intestinal atresia, anorectal atresia, and Hirschsprung's disease, as well as cleft lip with or without cleft palate. The offspring of women exposed to SSRI or SNRI were at a higher risk of digestive system anomalies. The next category was the risk of abdominal birth defects. Common defects in this category is diaphragmatic hernia, omphalocele, and gastroschisis. The offspring of women exposed to SSRI or SNRIs were at a higher risk of abdominal birth defects. The next category is the risk of musculoskeletal congenital malformations. Common malformations in this category consist of craniosynostosis, limb reduction defects, club foot, and talipes equinovirus. The offspring of women exposed to SSRIs were at a higher risk of musculoskeletal congenital malformations. However, no association was observed in the SNRI group. For these last 3 malformations studied, they determined there was no association observed between SSRI or SNRI use during pregnancy. So they were the risk of congenital malformations of eye, ear, face, and neck, the risk of congenital malformations of the genital organs, and the risk of congenital malformations of the respiratory system. So once again, there was no correlation between either SSRI or SNRI use and an increased risk of any of these birth defects. So just to summarize all of that information, this meta-analysis determined that babies exposed to SSRI in utero were at a higher risk for the following birth defects: congenital cardiovascular abnormalities, congenital abnormalities of the kidney and urinary tract, congenital anomalies of the digestive system, abdominal birth defects, and musculoskeletal congenital malformations. And then for the in utero SNRI exposure, these babies are at an increased risk of the following birth defects: congenital cardiovascular abnormalities, congenital abnormalities of the kidney and urinary tract, congenital anomalies of the digestive system, abdominal birth defects, congenital malformations of the nervous system. So now it is time for your second pop quiz. So this one is a true or false question. So due to the risk of SSRI exposure in utero, it is recommended that all pregnant individuals or individuals seeking pregnancy stop their antidepressant medication. So I'll give everyone a minute to answer this question. As some of you may have guessed, since this question is being asked, the answer is not as straightforward as it seems. The correct answer is false, and here is why. There is a significant amount of negative effects of depression going untreated in pregnancy. First of all, for the pregnant individual, they experience a higher risk of postpartum depression, a higher risk of suicide, and they are more likely to engage in high-risk behaviors like smoking, illicit substance, and alcohol abuse, all of which prove to be harmful for both the individual and their baby. This is a quote from the National Institute of Health multi-center trial, which included 201 pregnant individuals who suffered from depression. In the course of the study, they found that 68% of women who discontinued their medication during pregnancy had major depressive relapses, compared with only 26% of women who maintained their medication. Further, those who discontinued their medication were 3 times more likely to be hospitalized and experience complication during the pregnancy. So when it comes to the pregnant individual's health, it seems maintaining the medication has the best outcome. When it comes to the baby, there are also significant risks to untreated depression during pregnancy. These consist of a higher risk of prematurity, a higher risk of low birth weight, a higher risk of intrauterine growth restriction, and a higher risk of preeclampsia, which can be very dangerous for both the mother and the baby. There are also long-term effects into childhood associated with in utero untreated depression, such as higher impulsivity, maladaptive social interactions, as well as cognitive, behavioral, and emotional difficulties. So as you may notice, these risks do tend to be similar to the risks that we see with babies who are exposed to SSRIs in utero. So these next few slides will cover a few studies which provide more detail to that previous slide of risk to the fetus associated with untreated depression during pregnancy. So this specific study was from 2020, and it was conducted in a region in Ethiopia, which included over 6,500 participants. This study looked at various risk factors associated with pregnancy, one of which was depression. They found that the adjusted risk of stillbirth was 3.22 times greater among study participants who were depressed during their pregnancy. This is thought to be related to an unbalance of hormones in the body, including elevated cortisol levels. Elevated cortisol has been associated with the discontinuation of the proper function of the placenta, which would result in reduced oxygen supply to the fetus. Low oxygen to the fetus could result in miscarriage, or in this case, stillbirth. Here is another study, and this one was conducted in 2018 and included over 200,000 mother-baby pairs. This study also included case control analysis of siblings, where one sibling was affected by maternal depression and another sibling was not affected by maternal depression. The conclusion drawn from the study suggested that women who experience depression during pregnancy have a higher risk of having a child with autism spectrum disorder. Unfortunately, they determined that this was a risk factor regardless if the pregnant individual was being treated with antidepressants. But, as stated before, pregnant individuals who maintain their SSRI medication are less likely to relapse into major depression. If their depression is successfully being treated with SSRIs, the thought is that the risk factor of autism is decreased. And lastly, this is another meta-analysis published in Georgetown Medical Review. This meta-analysis looked at all the studies published from 2018 to 2023, which studied the effects of untreated depression in pregnancy. First, we will talk about the chemistry of these babies' brains. So as we learned from a previous study, individuals suffering from depression have higher levels of cortisol, which unfortunately does also get passed to the baby. This can result in abnormally regulated fetal heart rate variability, which results as low fetal heart rate variability. Additionally, untreated major depression in pregnancy has been associated with environmental changes to a fetus's genome that leads to improper growth of the amygdala, hippocampus, orbital frontal cortex, and ventromedial prefrontal cortex. So unfortunately, it appears that the baby's brain can be affected and may explain some of the long-term negative behavioral outcomes of these babies. As far as the behavioral aspects studied in the meta-analysis, they found a strong correlation between maternal depression and early childhood developmental delay in all aspects. And these affect the offspring's mental, emotional, social, behavioral, linguistic, and physical development. So just like with in utero SSRI exposure, there can be significant long-term outcomes to depression during pregnancy. So those studies from the meta-analysis are listed below for anyone interested in more specific information on the effects. So what has probably become apparent to everyone is that this really is a lose-lose situation. If someone suffering from a mental illness becomes pregnant, there are risks at maintaining or starting medication, including birth defects, mental delays, and behavioral problems. And there are also risks to having untreated mental illness, like premature labor, stillbirth, and developmental and emotional delays. Therefore, it is important for those individuals suffering from depression who are pregnant or looking to get pregnant to discuss with their doctor the best course of action for their specific situation. So there is no right answer on SSRI use during pregnancy, but it is important to test for it, especially since the withdrawal symptoms experienced by the baby is nonspecific and can go unnoticed. Without testing, these babies can fly under the radar. Testing allows for better, consistent data for NICU programs. It also allows for intervention by connecting patients with resources. And specifically for those in pilot programs or research programs, it allows for more research of long-term outcomes, which, as we talked about earlier in this presentation, is something that is lacking in the literature. One matrix that you can test for SSRIs in is umbilical cord. Umbilical cord is an ideal matrix, especially for research, as it is immediately available at birth, and it is the property of the newborn, so no parental permission is needed. The detection window is the second half of the pregnancy, and it almost always has sufficient volume for testing, unlike meconium testing. The results obtained from umbilical cord testing is very consistent with the results obtained from meconium testing. So thank you all so much for your time and attention, and I would be happy to answer any questions that you may have at this time.
Subscribe to our channel and visit our website for more information.